ICU at Emory St. Joseph Hospital, which is on the north part of Atlanta in an area we coin Pill Hill. And I'm going to talk to you about end organ perfusion and dysfunction, and really what this is a talk about unresuscitated shock and organ function. And I'll start by stating the obvious, and that is shock is bad. I could stop there, actually. Hypotension is a true critical care emergency, and where you have inadequate organ perfusion, multiple organ system failure, and death. And this is a vicious cycle where when on resuscitation you get hypotension, impaired microcirculation, heart failure, decreased cardiac output, which can further worsen hypotension. In the renal system, unresuscitation leads to decreased renal blood flow, impaired microcirculation, kidney failure, and then once kidney failure is established, you can get blood flow shunted away from the renal system, which can further exacerbate the kidney failure. And with hypotension, even short periods are dangerous. The brain, the heart, and kidney are the organs that are most at risk, and we're taught from early on in our training to defend the mean arterial pressure, defend the MAP. And it often comes up on rounds, at least with me, is why do we pick a MAP of 65? What's so magical about that number? And it has to do with this phenomenon. This is an autoregulation curve that many of you, I'm sure, remember from medical school. And it describes organ blood flow through a wide range of blood pressures. And you can see in the physiological segment, sort of in the middle, that organ blood flow is consistent across many blood pressures. But this curve can shift in disease states. In hypertension, it can shift up and to the right, and in shock, it can shift down and to the left, and can even flatten out so that blood flow through an organ is really dictated more so by a pressure-flow relationship than by autoregulation. So there are a lot of studies that have come out that have looked at blood pressures above 65, and this is a recent review of a number of those studies. The largest of which was the ASFAR study in 2014 in the New England, which looked at almost 800 patients and compared blood pressure of 65 and 85. But you can see throughout all of these studies, various targeted mean arterial pressures, anywhere from 60 to 90, various outcome measures, and various mortality numbers. But the results, by and large, of all these studies are that there's no difference when blood pressure is above 65. And this is a Kaplan-Meier from the ASFAR study looking at, again, blood pressure 65 versus 85. And you can see that the survival curves are superimposed. And this is another study from that same review by David Ledoux, looking at 10 patients with septic shock, and he looked at microcirculatory parameters, and he found, again, no difference between a blood pressure of 65 and a blood pressure of 85, and these included parameters such as lactate and urine output. So what about a MAP of less than 65? Well, doing a study, of course, comparing 65 to less than 65 would be unethical. And our data is fairly circumstantial. The 2012 Surviving Sepsis Guidelines states improved outcomes above 65. And in the same year, there was a study looking at persistent hypotension without an increase in blood lactate levels, which was associated with less organ dysfunction and mortality. And then just last year, a nice study of greater than 800 septic shock patients looking at a MAP of greater or less than 65 and found that hypotension was an independent predictor of mortality. And this is a Kaplan-Meier from that study. This is two sets. The two upper curves are lactate less than 2. The two lower curves are lactate greater than 2. But in both sets, you can see improved survival with MAP greater than 65. So what about on an organ-specific level? And this is a big study by Dan Sessler and the folks at Cleveland Clinic looking at intraoperative hypotension and the association with that on organ dysfunction. And he found, and this is graphical data from that study, looking at blood pressure, and you can see that the probability of organ failure, the left is kidney injury, the right is myocardial injury, increases as blood pressure falls. And time is of the essence as well, and this is data from the same data set looking at the odds ratio for organ injury by time spent under a map of 55 millimeters of mercury. And you can see that within a few short minutes, organ failure starts to occur, and this increases linearly as the duration of hypotension extends. More data, looking at over 5,000 patients, also intraoperative patients, looking at intraoperative hypotension and the association of acute kidney injury. And the results are similar. As blood pressure falls and as the duration of blood pressure extends, so too does the proportion of these folks experiencing kidney injury. Same story with myocardial injury. This is almost 900 patients looking at intraoperative hypotension and the association with myocardial injury, and similar results. As blood pressure falls and as the duration of blood pressure increases, so too does the myocardial injury. And interestingly, this study also found the same results looking at relative levels of hypotension compared to baseline blood pressure, in addition to an absolute value. When we're talking about hypotension and the brain, we're talking about delirium. And this is a nice study in which the authors looked for risk factors that were associated with the onset of delirium. This is 100 consecutive patients undergoing colorectal surgery. And they found that in univariate and multivariate regression analysis that intraoperative hypotension was the single largest predictor of the onset of delirium. Same results from this data set of 90 consecutive urological surgery patients, in which they found that hypotension during surgery was a statistically significant contributor to the onset of delirium. So we know that we need blood pressure, at least at some level, in order to preserve organ function, and that there needs to be some sort of pressure gradient through which blood flow can flow through the organ. And this is sometimes referred to as the vascular waterfall. And you can imagine at some point when the mean arterial pressure falls, it will fall to some point where the blood flow through the organ will cease. And this is often referred to as the critical closing pressure. Is this 65 millimeters of mercury? Is it 60 millimeters of mercury? Is it different for every organ? Is it different for every patient? The answer is yes to all of those, although determining the exact number is a bit of a challenge. So just turning to a couple of organ-specific mechanisms, I'll start with the hypoperfused septic brain, where cerebral perfusion pressure is governed by the equation MAP minus the CVP, or intracranial pressure, whichever is higher. And we know, based on accumulating evidence, that this should be somewhere between 50 and 60 millimeters of mercury. And unresuscitated shock can lead to decreased cerebral blood flow, plus or minus some contribution maybe of hypoxia, which leads to the onset of encephalopathy. And again, this is the autoregulation curve, which shows that cerebral blood flow is fairly consistent through a wide range of physiologic blood pressures. But you can see as blood pressure falls to some point, so too will cerebral blood flow. And remember, in shock, that autoregulation curve can flatten out so that that range through which cerebral blood flow remains constant can shrink and even become obliterated. But we do know that delirium exists even when we preserve our blood flow. Everyone has patients in their unit where blood flow is fine and they're still delirious. So it's not just systemic pressure. I think there's some contribution of the microcirculation. And this is a study by David Pfister looking at cerebral perfusion in sepsis in 23 patients with shock. And some of which developed delirium and some of which did not. And he found that there was no difference in systemic or cerebral blood flow between these two groups. But he did find that an autoregulation index, which was a mathematical construct of MAP and cerebral perfusion, was statistically different, suggesting that there's some microcirculatory dysfunction. So does cerebral perfusion pressure even matter in the brain? Well, I think it does, but I think it's a multifactorial model, including cerebral perfusion, impaired autoregulation, systemic cytokines, neuroinflammation, imbalance of neurotransmitters. Turning to the kidney, renal perfusion pressure is governed by the equation MAP minus the CVP, or intra-abdominal pressure, whichever is higher. And we know from a large amount of accumulated evidence that mean arterial pressure needs to be anywhere from 60 to 80 millimeters of mercury in order to preserve renal perfusion pressure. And this is a study by Burgoyne looking at 28 patients with septic shock, randomized to either conservative or aggressive blood pressure goals of 65 versus 85. And Dr. Burgoyne found no differences in renal microvascular parameters in these two patient populations. But again, this is above the autoregulatory lower limit of renal blood flow. But we do know that something happens in hypotension and kidney injury. And this is a large data set from the folks down south looking at over 30,000 patients with sepsis-related diagnoses. And they found that with statistical significance, mean arterial pressure was associated with the onset of acute kidney injury. So I think to fully understand what happens inside the kidney, it's worth taking a look at the renal microanatomy. And GFR really depends on a number of factors, including adequate renal blood flow, which of course is governed by renal perfusion pressure and systemic blood pressure, but also the adequate milieu of microcirculation, including adequate afferent arteriolar dilation to allow for blood flow into the glomerulus, and sufficient efferent arteriolar tone to allow for the existence of a transglomerular pressure gradient, and then blood flow across Bowman's capsule. And in hyperdynamic shock, you have increased cardiac output and an increase in renal blood flow, but you also have systemic, system-wide vasodilation, both on the macro and the micro level. And so you have efferent and afferent vasodilation. Because efferent tone is higher at baseline than afferent tone, you have preferential efferent vasodilation over afferent vasodilation and obliteration of the transglomerular pressure gradient and a subsequent fall in GFR. And as I mentioned in my first slide, this is a vicious cycle. Once kidney injury is established, everything shunts away from the kidney. You get afferent and efferent arteriolar constriction, and GFR continues to fall basically to zero. And graphically, this is sort of what it looks like. The blue line is renal blood flow, and in states of hyperdynamic shock, you have initial renal blood flow that's high, but because of efferent arteriolar dilation, you can see on the x-axis as it moves to the left, you have a fall in GFR, and you can imagine what would happen if that renal blood flow went away. But I think it's more than just hyperperfusion of the kidney. I think that's possibly the inciting factor. The low renal blood flow could potentially set off this mechanism, but I think there's more to it. You have inflammatory mediators, you have reactive oxygen species, you have nitric oxide, you have endothelial disruption. Something happens to cause tubular injury and microvascular injury. And even despite the restoration of renal blood flow, we still have persisting acute kidney injury. Again, we see this in all of our patients in the ICU. So, there's something more to it than just the plumbing. And I think this is an interesting area of research, too. There's perhaps a dozen studies right now looking at the septic acute kidney injury phenomenon, and all of these relate to some inflammatory or immunological modulation. Turning lastly to the myocardium, the phenotype sepsis-induced myocardial dysfunction, described as a reversible decrease in ejection fraction. an increase in ventricular dilation, less of a response to fluid resuscitation, and some catecholamine resistance. And this plumbing problem can be described as early hyperdynamic shock with an increased cardiac output and a decreased systemic vascular resistance. And this devolves into a late hypodynamic phase with increased resistance and decreased cardiac output. And when this is under-resuscitated, it leads to tissue hyperperfusion, cool skin, organ failure, and death. But again, is it really just about perfusion? And this is an old study by Robert Cunyon, 28 years old, looking at coronary circulation in human septic shock. And he found, interestingly, that coronary blood flow was similar in patients with septic shock compared to his control patients. And more importantly, in those patients with shock, there was no difference in coronary blood flow between those who developed myocardial depression and those who did not. So I do think that there's something more to it, and perhaps we have to turn again to the microcirculation. And this is a canine model of endotoxemia in which the authors took biopsied segments of canine myocardium and compared and looked at them under the microscope and compared the blood flow through these biopsied segments to a normalized dog heart. And you can see in the control panel on the left that the regional flows correlated nicely with the normalized canine heart blood flow. And on the right, with the endotoxemic model, you can see that the regional blood flow varied tremendously compared to the normalized flow. There may also be some sound teleological reason that we see this phenotype of the myocardium in shock. And this is another old study by Margaret Parker looking at 20 patients with septic shock. And she found that ejection fraction was lower and end diastolic volume was higher in survivors compared to those that succumbed to their illness. And the hypothesis she put forward is that perhaps this left ventricular dilation is some compensatory mechanism in order to preserve cardiac output. So I don't think this is just a plumbing problem. We know that there are the presence of cardiac depressants, DAMPs and PAMPs. We know that there are high catecholamine levels and decreased responsiveness to catecholamines. We know that there's calcium channel dysfunction, and we know that there's mitochondrial dysfunction. Speaking of the mitochondria, this is a 28 septic shock patient study by David Brealey looking at levels of ATP as a proxy for mitochondrial health. And he found that compared to survivors and controls, those that succumbed to their illness had a lower level of ATP. And likewise, ATP was inversely correlated to levels of norepinephrine in those shock patients, of course, before they died. So does MAP really even matter in the septic heart? Sort of. This is an induced and then resuscitated porcine model of shock in which the authors plotted micro versus macro circulation, and they found that below 71 millimeters of mercury, that resuscitation mattered for coronary microcirculation, but above 71 millimeters of mercury, there was no effect on tissue perfusion. And this curve looks an awful lot like the tail end of the autoregulation curve that I've shown a couple times tonight. So across all these organs, does MAP matter? Well, kind of. We know that you need a certain blood pressure in order to perfuse the organs or they'll fail. But the organs fail despite this blood pressure. So I think we need to look at microcirculatory and inflammatory mechanisms to more describe organ failure. And there are, moreover, there are organ-specific autoregulatory ranges. But in shock, maybe that doesn't matter. Remember that curve flattens out, and blood flow is determined by a pressure-flow relationship rather than autoregulation. But ultimately, the body is smart, and it will shut blood flow away from the non-essential organs, the skin, the non-exercising skeletal muscle, the splanchnic viscera, in order to defend those vital organs. By way of dovetailing into Ragi's talk earlier, some strategies for resuscitation and reperfusion. Obviously, you have to diagnose your flavor, shock, a good physical exam, the dynamic measures he spoke eloquently about. Is the shock fluid responsive? Is it pressor responsive? And this is a nice chart I found from John Prowell and Ronaldo Bellomo, looking at various parameters and the effects that fluids and vasopressors have on them. And this is kidney-centric, but I think there are some generalizations that are worth mentioning. With regard to mean blood pressure, fluids may or may not improve this, depending on whether or not you're fluid responsive. Pressors will, of course, improve your blood pressure. With regard to cardiac output, again, fluids may or may not help this, depending on Starling mechanisms. And pressors may or may not help this, and this really depends on the flavor of pressor, whether it's an inotrope or a pure afterload or what have you. With regard to microcirculation, fluids really have no direct effect. Pressors have a variable effect, and I think this is an interesting area of research as well, especially in the kidney, where we can possibly see differences in afferent versus efferent effects of pressors. With regard to venous congestion, obviously fluids will increase this, and there's no direct effect by pressors. And then lastly, it's worth mentioning side effects. As I'm fond of saying on rounds, you have to rob Peter to pay Paul in critical care. Everything has a side effect, including fluids and pressors. With fluids, it can be interstitial and pulmonary edema. With pressors, it's really agent-specific, but can include tachyphylaxis, arrhythmia, digital ischemia, electrolyte imbalances, to name a few. So by way of conclusion, I'll mention a couple key points. Shock is bad, and time is of the essence, of course. Hyperperfusion of the vital organs causes their dysfunction, but it's not the only thing. It's not the only contributor. Reperfusion and resuscitation may mitigate, but it will not eliminate the disease. And I think there's a strong role for individualized and organ-specific perfusion goals.